I'd like to say good morning to all of you again. My name is Bohdan Zaitsev, and I'd like to welcome you to Shared Care Committee 101. Now, I'm going to be your host for about the next 45 minutes or so as we take a look at the history, issues, and work of the Shared Care Committee. So joining me on my immediate left is Dr. Gordon Hogue, co-chair of the Shared Care Committee and a specialist physician who is medical director for laboratory medicine with the Vancouver Island Health Authority. Seated as well here is Jeremy Higgs, Director of Medical Services, Economic Analysis with the Ministry of Health. We have Dr. Bill Cavers, not Carvers, but Dr. Bill Cavers, family physician practicing in Victoria and co-chair of the General Practice Services Committee. And last, but certainly not least, Clay Barber, executive lead of the Shared Care Committee. Now, the format for this morning's session will be that of what we call a courageous conversation, a frank, open, and honest dialogue that'll be informed by the spirit of the quote you see on the side screens right now. So, to cases, as it were. Bill, I'd like to start with you, if I might, please. I'd like to ask you to connect some of the dots for us, if you will. How did stories like the one that we just heard from Jocelyn kind of inform the thinking that led to the creation of the Shared Care Committee?
Well, I'm going to have to roll the film loop back a few years. The GP Services Committee was created through the 2002 agreement, and we first met in February of 2003 in room 595 of the Ministry of Health. And collaboration at that time was not a big ticket item on the hit parade. We had finished an arm wrestling match, and basically we walked into the room and ministry sat on one side of the table and we sat on the other, and we glared at each other. And that didn't work. So we managed to get a few initiatives out, and then in the 2006 agreement, because of the relative success, a new way of doing business, the Specialist Services Committee was formed, and then between the two, there was the Shared Care and Scopes of Practice Committee. Now, to share a bit of an embarrassing thing, the Shared Care and Scopes of Practice Committee at that time, from the conversations in negotiations, was more about us than about patients. It was more the friction between GPs and specialists and why weren't you doing what you're supposed to. The good news about that is when we got into the room, the physicians and the ministry representatives in the room said, we don't want to do that, because we're looking at patient care gaps. And so the same culture should come into this room here, and that's how it started.
Oh. I don't think that that's written down anywhere.
No.
He just keeps it in his mind to share at events
I
like
see.
this. Yeah.
Gordon, can you share put any color commentary on that, and anything you'd like to elaborate from that?
Well, I think those were the early days. I think we've matured, but I think we're still the young kid on the block. And maybe it's more like a family relationship. You know, you've got these parents, and one's GPSC, and the other is SSC. They don't always share the same thoughts, you know, just something like parents.
Yeah.
But we're the kid in the block, because we're the shared care group, and we represent that interaction between these two. And I think it's fair to say that the interaction is getting more exciting every day.
Well, we look forward to hearing a little bit more about that. I want to parse one point, if I could here, with regards to the creation of the committee. SCC, as you pointed out, was kind of the progeny of two parents, a joint project between the General Practice Services Committee and the Specialist Services Committee. And it was created as part of and embedded in the Physician Master Agreement. And I'm curious, and Jeremy, maybe I can turn to you around this for your perspective on it. What's the significance of situating the work of the Shared Care Committee within that broader framework of the Physician Master Agreement?
Well, the master agreement is where the ministry and the medical association have really developed a relationship that didn't exist before. Certainly, when I came to the ministry in 2001, that's when there was a lot of antagonism. The Shared Care Committee and the other collaborative committees, the Specialist Services Committee and the GPSC, I think have really been indicative of the really big development that is the relationship between the government as the payer and the insurer of medical services and the physicians as the providers, and the development of a relationship where we actually solve problems together. And one of the best pieces of advice I got when I joined the ministry was the best way to get physicians on side to solve problems is to get them to help you solve the problems. And don't be antagonistic, and don't take an anti-doctor position. Work with the doctors, and you'll get a lot further. And so having shared care is really just an evolution in that. The GPSC was the first, and there was a real reason to be for GPSC. And then after GPSC had a few years under its belt and actually got a bigger budget and a bigger mandate and such, Specialist Services Committee came and it had a mandate. And then shared care came and it had a small mandate and a temporary status, and then it became permanent and actually got a budget. So the significance is that it is indicative of the developing relationship between the taxpayer and the government and the medical association, and then of course the health authorities, which is another chapter.
It's interesting, relationships are conversations, and those conversations that happen, it's all what you're describing there, Jeremy, brings up the interesting question of membership, and we've identified some of the key players. And Clay, I'm going to go to you and ask you, who gets to sit at the SCC table?
Well, as Jeremy indicated, it's really based in the Physician Master Agreement. So originally it was 4 members from Specialist Services, 4 members from GPSC, and a balance between government and BCMA representation. We realized that makes sense from an agreement point of view, but it didn't make sense from actually getting the work done. So we've expanded it. We looked at physicians who weren't otherwise captured by these 2 groups, ER docs, hospitalists, for example. We've invited them as guests. Within the PMA, the health authorities aren't really named as a separate group. They're part of the ministry's identity. But we can't ignore the fact that there's more than one health authority, that we have to have good representation across the province. And so we've expanded the membership to look at the groups that we need the voice at the table, not just what the agreement requires. In the PMA, we have this idea of voting members. I've yet to see one vote ever come to any of these committees, and maybe it did in the early days that Bill can remember, but I honestly haven't seen a vote come to the table in 6 years. So I think it's about the collaboration, and it's about having the right people at the table.
Yeah. Speaking of which then, is everyone there who needs to be there? Or are you missing anyone right now? Clay, Gordon?
I think we're open to suggestions. That today is a day for ideas. Okay. So if somebody can identify something that they feel is important for us to add to this, we'd be very willing to listen. I think that's been the property of the Shared Care Committee. We take ideas internally, we try and put them into our system so that we benefit the whole. And certainly, I can't think off my head of any gap that we have presently, but certainly look forward to people's ideas after today, after they see what sort of things we're doing.
Terrific. Bill?
This is an evolving culture, and so I think there's some developing gaps. First of all, we've been talking about the physician master agreement and physician committees, and if we're going to be really truly doing shared care, we have to start looking at the future and realizing that we have a lot of trained health professionals that are involved in patient care, righteously involved in patient care, and need to be in the room to start talking about the overall spectrum. The other group that should be in the room is one that's just come into existence. That's the Interim First Nations Health Authority. And we've been having conversations at GPSC about inviting them to join. And I think they should be in the room because the population of First Nations is a difficult one to provide care to because of the scope across the province, and they need to be involved.
Okay, very good. We've been talking mechanics, how it works. Let's talk a little bit about your mandate. I'd like to hear your elevator pitch, if I could. What is it that the Shared Care Committee strives to do? What are your goals?
Well, I think I can perhaps start that off. I'll give them opportunity to sort of add,
Good?
Will be the
But I think really it's about this knowledge transfer that you've heard about, and building relationships. And I think even what has already been shared today during the initial phase of the morning and the keynote address, and the posters, they really tell our story about what we want in terms of collaboration, building something, leveraging it, making it happen across the province, trying to do things with respect and dignity and trust. In all the partnerships, and allowing that to really add to professionalism to our patient care practice with respect to each other and to our colleagues. And perhaps the thought that we have is the greatest is we want this to be something that's sustainable, something that really adds to the experience of the people of this province throughout the future days. And I think the initiatives are just an example of what sustainability will look like in the future. Over to you, Bill, and to you, Clay.
Yeah, I would just add that really much of our work is grounded in the idea that improved relationships will improve communication. Improved communication will result in better patient care. And so all of the work that we do is grounded in that premise. And so I think as far as a mandate goes, the mandate is telling when people raise their hand how many physicians were in this room. I looked around the room and I was surprised that we have that many physicians here. We've got that level of engagement. Our job now is to actually expand that across the province, to not only make it sustainable, but actually to grow the initiatives that are already underway across all of the communities, not just in our prototype communities.
Can I ask you, Jeremy, to kind of maybe sound a note from the ministry perspective on goals and mandates, and what from the ministry perspective is really important, what really resonates there for you?
Well, if I had a script, I'd read the core mandate and then what the master agreement says. But I think that certainly the work of the Special Services Committee and the GPSC, which I'm a member of SSC, and I participated in GPSC for several years in a few different ways, and then shared care, is that the ministry is really interested in not only the relationships, but of course in the patient care and improving, finding those areas that really need to be addressed, things that fall through the cracks. The youth transition is an excellent example of that. And both SSC and shared care have done some specific work on that. I'll let Bill talk about anything that's been done for GPSC. But that's a really big piece. Another one that we're looking at is in pain, where Special Services Committee and shared care are doing work on addressing chronic pain. So a big thing is addressing patient needs that are going unmet, but also that require that the physicians and everybody else that's involved to work together. And the relationship thing is big. So you've got the specialists, the GPs, the health authorities, the allies, the nurses, everybody. And I think that's, from the government point of view, that's where we want to be able to make a lot of progress. It's very difficult to do all of that. It takes a lot of work. It takes a lot of relationships even within the ministry. And so.
Okay. You've given me a great bridging point here to a question. Lots of conversation already this morning about initiatives, where they are, what they are. This afternoon, you'll all have an opportunity to go deep, as Kelly was talking about a little bit earlier today. But I think the people here today would be really interested in finding out about how it is that you determine what initiatives you proceed with. Is there some kind of filtering or assessment process that you use?
We take bribes.
If you know, Clay?
No, I think, really, shared care is a partnership between general practices and specialist committee. So many of our initiatives come from those parent committees. It's ideas that are percolating inside specialist committee or inside GPSC, and they need the other partner at the table. And so we're a natural sort of, I refer to it as a skunk works or a learning lab. We're the skunk works. If anybody knows motorsports at all, they'll know what I'm talking about. George knows what I'm talking about. At any rate, it's about identifying within the system what is going on that really is shared care. We don't release RFPs, at least we don't now. We might in the future as we need to. But really what we're focused in on is leveraging what is already happening in the system and taking that opportunity to fill in whatever gaps exist and then taking the learnings from that and spreading it provincially. So it really is about working with our partners to bring the initiatives together.
Okay.
Obviously, we have a framework of triple aim, so it has to fit within these frameworks, but certainly that's how it comes to us.
Okay, so new project coming forward. Someone's got a great idea. How do I get into your mix?
Well, you saw the people who stood up representing the committee, and that's really where you get it addressed.
Okay, fair enough. Now, at the risk of stating the obvious, doing all of this takes money. How much of it is there? Where does it come from?
Millions. You want to answer that?
As the money guy. The budget right now is $6 million for shared care. They're getting another $500,000. We are getting it in April 1st, 2013. But the other thing that actually has happened is that the Shared Care Committee has approached Special Services Committee and the General Practice Services Committee when it's appropriate to get more funding to do specific things, especially where things are coming together. The chronic pain piece for a practice support program is a good example of that, where both committees have put money into that. So Shared Care actually has $6 million compared to considerably more for GPSC and SSC, but they do have that ability, being that sort of bridging committee, to identify these sort of synthesized projects that require synthesized funding.
Yeah. Bill, anything to add to that?
About the money?
Yeah.
It's always about the money.
It's always about the money, yeah, absolutely.
And we need more money, Bill.
Nicola?
Maybe we should pull up another chair.
So going back to the workflow I was talking about before, what's happened at Shared Care is a realization that when you actually get above the, I'll call them superficial or minor issues, when you start getting patients that require ongoing care across different providers or different facilities at different times, you're immediately into shared care. How do we actually make these transitions work? How does it work efficiently? How do you prevent the person from having to tell his or her story 25 times? And how do you make the slip up when I refer to Gordon and Gordon changes the medications again and passes the patient back to me and doesn't tell me? All those sort of things. So when you're actually looking at overall patient care, shared care is actually the primary focus. And then in the wings, there should be the GP services working with GP issues and the specialists working with the others. So as far as the culture, we've seen the culture of collaboration grow in the last 10 years, 12 years. We've seen some real gains, and we're seeing a shift in focus now into how do we actually work better together from a patient care perspective. So I really believe the future initiatives are largely going to be involving shared care, and then the GP services and the specialist services committees will deal with their own smaller issues. And by the way, for the audience, Kelly forgot to tell you that in the back of your packages, there's a glossary for all the acronyms we use.
Jeremy.
I just want to add that that a big thing is that it's not, that the dollars are one thing, but there's actually so much effort that goes on underneath that we fund things, but there's the health authorities, there's the ministry staff, and the health authorities put a ton of effort into all of our projects across the three committees, and they do come to we do have their representation, but they are really, really key partners in all of this as well.
I'm hearing that you're saying there are ways to make things work, and that's what it is you're all about. It's about making these things work, and I think that it's very much in evidence, the outcome of that work here today as part of what it is that we're showcasing. And it leads me to my next question, and I'd like the four of you each to take this one under consideration and give me a perspective on it, if you don't mind. I'd like to ask you, what is currently impossible for the Shared Care Committee to do that, if it were possible, would change absolutely everything? Gordon.
Silence. Well, I have a pet subject, And
How about it?
everybody at the GPSC and the Specialist Service Committee certainly knows what that pet subject is. It's called genomics. And right now, genomics is sort of the new world. And I think it might change everything. And are we prepared to, and is it impossible for us? I think it is at the present time because maybe we're just not right there yet. But, you know, we'll change it for the patients because we're going to change medicine and flip it on its head maybe a bit. Because it's going to be allowing for personalized medicine. You hear a lot about that. It's going to allow for preventative strategies to be formed. The predictiveness of what our care is going to look like for us will change. And it's going to be participatory from the patient's perspective. I think that at the present time, it would be impossible, but maybe that's just not allowing the cart and the horse to get together at the same time.
Okay. Clay, how about you?
I think the biggest thing or the thing we have to overcome is really the capacity to do this work. And so we're a small committee. The members sit on the other committees, so trying to find time is very difficult. But I think where we need to move and really going from impossible to possible is what Bill said earlier on. It's bringing in the allied health, bringing in the things outside the physician master agreement. So it's about bridging beyond our own mandate and looking well beyond that to truly bring shared care into the province.
Great. Jeremy?
Well, always time is, I think, a big thing. It's impossible to do things fast. So it would be great to be able to bring some speed to things. But being a bureaucrat and, you know, having to go through process for very many things is, you know, it's just part of it.
Right.
But it would be great to be able to do things quickly. And of course, there's always I wouldn't say it's impossible, but it's certainly, you know, a time thing is being able to have the culture of quality throughout in a whole bunch of different ways. And I'm really just using a very general term to describe something that's very, very complicated.
Yeah. Okay. Last word on this subject to you, Bill.
What can we not do? that would
Yeah,
change?
what's currently impossible for the Shared Care Committee to do that if it were possible would change everything?
Boss everybody around.
I thought you were going to do e-health.
No, well, hang on. If we could boss people around, it would change everything because it would ruin everything. The whole power of this process is the fact that people are collaborating together because it's working for the different partners involved. It's working for the patients, it's working for the professions, working for the health authorities, it's working for the ministry. And if you start getting apart from this collaborative process, you would destroy that sort of, this thing of ours, the Italians calls it a cosa nostra. You'd lose the flavor of the process.
Yeah.
But if I could boss people around, what I'd do is I'd take a look at the information technology section of the health authorities and ministry, and I'd make the IT stuff serve us in the clinical workflow instead of us serving them.
I think you have some kindred spirits in the audience.
And if you want to talk to me more, I'll be out in circles.
So that's a key area that would make a big, big difference. We'll use that to kind of look ahead then as we look out over that next 3 to 5 year period of time. Your top priorities that you see for the Shared Care Committee looking forward.
I think our number one is actually to do what we're doing now and really do it well. Get that spread, take those lessons learned, and really embed them in a sustainable system as opposed to adding new things onto our plate.
Okay. Gordon.
I think Clay's hit it with our resources and looking at where we're at today. I think there's so much that we can leverage for the province. We really need to nurture, foster those programs in other jurisdictions and just know what the fruit is for all the patients and have that evaluated in terms of how effective care can change.
Okay. Bill?
Do the projects, but subvert the IT process. So that they voluntarily come to us and beg to be let into the room so that they can help us, so that I and every other person and the patients have the information they need at the time they need it, where they need it, and don't get me going.
But we like to get you going. Jeremy, over to you.
The number one priority, I think, is that the three big committees, the three big collaborative committees actually work collaboratively themselves and make their effort such that it's the effort of the whole is more than the sum of its parts. Because I think that because the membership of the committee is derived of people from the other two committees, I really think that there's an awful lot to be leveraged in terms of expertise and knowledge. And when you have people that are involved in 2 or 3 of these committees at a time, I think that that's a very big priority.
Okay. We're about to open the floor to questions. So those of you who are busily scribbling away in your field notes and jotting down your ideas, do get ready. We do have the 2 stationary microphones. We also have mic runners who will bring a mic to your table if that's more convenient. But I'm going to use my prerogative as the moderator to ask one last question of our guests here. And if I might set it up in a slight context. The news these days, of course, is full of the forthcoming U.S. election. And this is a useful context for this story insofar as I recall back in 2008, shortly after President Obama was elected and was on the eve of the first state visit he was making to Canada. I recall watching The National with Peter Mansbridge on CBC. And on Thursday evenings, they host their political panel, of course, At Issues, I think they call it. And there used to be a pollster, Alan Gregg, was on that, Andrew Coyne from Maclean's magazine, Chantal Hébert, who writes for the Toronto Star. And they were having a heated debate about the state of Canada-US relations and about what an incredible disadvantage Canada is at because it's so small compared to the size of the US. And Alan Gregg, the pollster, who's always a little bit of a wag, likes asking provocative questions and making provocative statements. He says, Peter, the problem is that right now there is no question in Washington for which the answer is Canada. So that set his fellow panelists quiet for a moment. But very quickly they recovered and you began hearing some very interesting responses where they're saying, well, in fact, Alan, there are questions. What is the American guaranteed source of fresh water heading into the 21st century? Canada. What is the source of secure energy supply heading into the 21st century? Canada. So the upshot of that is that there were answers to that question. So my challenge to you, gentlemen, is around that, not with the US election, what is the answer is Canada, but what is the question for which the answer is the Shared Care Committee?
Everything.
No. Not a question.
So for me, it's where can true collaboration actually be fostered?
Okay. The Shared Care Committee. Bill, how about you?
This is like Jeopardy. What's the arena for problems that address patients when they have to go across different facilities, providers, communities?
Okay. Jeremy?
What's the arena where government and physicians and health authorities can do a little bit of innovation and can address some gaps in care, serious ones, the ones
Okay.
that fall through the cracks.
Very good. Thank you. And to you, Gordon.
Well, I don't know what the answer is when it's everything is the answer.
Well, no, the Shared Care Committee is the answer. It's what's the question?
The question is, I suppose, we're here to answer the question of what really delivers what the patients need. And so the question to me and my mindset is always, what is that particular need of the patient that we're not addressing so that we can answer it with shared care?